senior ophthalmologist, my dear friends, a very good evening. I don't know what's more challenging, being the last speaker of the last session or managing cataracts with retinal pathologies. As far as the introduction goes, in the past 2 decades we have come a tremendous change both in cataract surgery as well as vitreoretinal surgeries. There is better technology, greater proficiency of the machines that allow us to do faster and safer surgeries with better visual outcomes and shorter recovery times. So we all know we have come down a long road as far as cataract surgery is concerned from the days of ECCs and today's sub 2 millimeters phaco incision, and so has the advancements in all the machines that are available. And so has the vitreoretinal surgeries from the days of only scleral bucklings and the bands to the age of now 23, 25 and now 27 gauge vitrectomy being performed. So what are the main disadvantages when you do only cataract surgery in patients who are having combined retinal problems? So there are lots of reports and published areas showing that when there is a patient having diabetic retinopathy and you do only the cataract surgery, they have found there is a progression of the diabetic retinopathy that is occurring, and also a lot of changes in the vitreous when we do cataract surgery. It is mainly due to the chamber fluctuation during phacoemulsification. There are some physical changes that take place in the vitreous and in the posterior hyaloid that leads to the vitreomacular traction formation later on. And in cases of retinal vein occlusions and either vascular diseases, there have been incidences of formation of epiretinal membrane. And we all know these vascular conditions, there's already a breakdown of the blood retinal barrier and a lot of inflammatory materials in the vitreous. So once post-cataract surgery, these things tend to increase. And so as even in ARMD, there are even reports saying that patients have been converted from dry ARMD to wet ARMD post-cataract surgery. So what are the disadvantages when you do only the retina surgeries? Only when you perform retina surgeries, we all know that the incidence of cataract is very high. One, it can be iatrogenic during the retina surgery because we'll have to do a good base excision, or sometimes for visualization we'll have to remove the lens. The other reason is all the tamponates like silicone oil, gas that is being used, and the cataract formation being faster. And all these patients, after we do a retina surgery, taking cataract surgery as a secondary procedure is even more difficult because you have weak zonules and now you don't have the vitreous at the back. So you will see sudden deepening of the anterior chamber and the whole thing going back. And when this happens often, and if you don't reduce the bottle height and all the parameters, there is a lot of chances of drop nucleus rather than the PC rupture. So that is why we choose that the combined approach is going to be an easier option when there is a patient with both these problems. So apart from all the good clinical history and a careful examination, that is very, very important, because good counseling to the patient pre-operatively is what is going to make him happy post-operatively. So good slit lamp examination, as all of us are doing with the 90 diopter lens, to see the posterior floor and to find anything that is obviously wrong in the posterior floor. Indirect ophthalmization also should be a routine, like how we are all doing tension applanation for glaucoma nowadays. I think even indirect should be a routine, because it's always better to find a tear in the periphery or something in the periphery like Neil's disease and tell the patient he's got this problem, then do the cataract surgery and then also refer to the retina person, rather than doing the cataract and then landing up with these things when the retina person sees. And sometimes fundus fluorescein angiography, because we have all the investigations, and I know that all our doctors nowadays have all the investigations with them. So when you see a picture like this and you always are going to diagnose it as, yes, this is a case of only moderate NPDR, we'll go ahead with cataract, but it may not be the same always, because only in angiogram you can see all these capillary dropouts, the enlarged FAZ. So when you have a pure macular perfusion, and this again, you can still go ahead with the cataract surgery because he has got cataract. So I'm not debating that, but I'm just telling you can always caution the patient that you might have only a 50% chance of improvement in the visual acuity. So when you say this, even if the patient reaches beyond your expectation, he's always happy, rather than a patient who's expecting 100% and then he reads only 50%. OCTs has become a mandatory nowadays, and I am sure OCT picks up most of the retinal pathologies unless it is a mature cataract. You might see that the signal strength may vary, which is a very important factor while doing OCTs, and you can actually pick up the ERMs, the wrinkling of the internal membranes. The basic thing is, you know there is a pathology here and you can actually show it to the patient, and the patient also knows there is a problem here. Even in grade 3 cataracts, you might get a diffuse picture like this showing that there are some exudates and some edema here. So you are aware that before the cataract surgery, his visual prognosis is going to be poor. And I think nowadays all your premium IOL patients, you have started doing OCT as a mandatory procedure to make sure that we rule out any macular pathologies. In those cases we cannot do, yes, an ultrasound is very, very necessary, because time and time again we have found patients having a retinal detachment, or those patients who have mature cataracts, they don't reveal it to you at the first time, and only when you remove the cataract, when you do a beautiful surgery and then you see, and then the patient tells you the history of the trauma, yes, he was diagnosed earlier, but he always wants good vision when it comes to the cataract surgery. So the combined approach is actually a good thing when there is both these problems. So it can be either combined cataract with medical retina problems or the surgical problem. So medical retina is going to deal with lasers, VEGF therapy and intravitreal steroids. I'm not going to go into the when and how. But the basic rule, we keep it like always treat the retina problem first. Make sure the retina is stable and then plan for the cataract surgery. So these are the two fundamental questions I ask myself every time. Will the patient benefit enough from the cataract surgery removal to make it worth the risk involved in the surgery? And will the cataract surgery cause the retinal problems to worsen? So the criteria for the combined approach will be a good patient selection, patient preferences, because some patients are very old, they do not prefer two surgeries to be done, so they prefer a combined approach. And the surgical technique is also demanding you need the right set of equipments to do both surgeries at the one go. So these are the various indications. Anything that is surgical indication combined with cataract, you can do a phaco vitrectomy. So as far as the steps, I think almost all the steps are going to be the same, but only challenges that we face is you always get only a mid-dilated pupil because already you have some iris atrophic patches because of the diabetic status and the age of the patient. They're usually elderly patients. And always trypan blue staining is safe because even though what you see is a red reflex, it is not actually the red reflex that you're getting from the retina. It is just the vitreous hemorrhage that is there at the back. And using a lot of viscoelastics is also very, very key because you have to use very less amount of phaco energy, because once you finish phaco emulsification and even the slightest edema that happens in the cornea, it is going to prevent us from further doing the retina surgery. And you can see the sticky cataracts is what we get in diabetics. It is not the actual nuclear sclerosis. So trenching is, rotating the nucleus will be a problem, but it is not necessary that always you will have to rotate the nucleus and then go ahead with the phaco emulsification. You can start the trenching method, and that time there is some amount of fluid that comes to the probe and causes a hydrodelineation. And if you can see here also that blood was actually the vitreous at the behind the PC and not the red reflex. So staining is very, very important. And yes, IOL implantation into the bag and put some amount of viscoelastic, and I always prefer to suture the session initially, and once the surgery is over itself, you can remove it on table. You do not have to leave the suture and remove it on a later period. So nowadays it's all basically going to be only 23 gauge vitrectomy, and slowly everybody is talking only about 25 gauge vitrectomy and 27 gauge vitrectomy. So these are all self-sealing wounds that you make with the trocar. And slowly I recommend all anterior segment surgeons also, when you have a PCR or you want to do a vitrectomy, it is better to go through the pars plana approach than the anterior approach. So these are three trocars that are placed. A good amount of vitrectomy is done because most of the time you see these blood are all sticking to the posterior capsule. So once you remove that, only you get good visualization of the fundus. So it's step by make sure your cornea is clear, then you remove the cataract, and then you can see all the diabetic changes. Nowadays with the advanced cutters and very high speed, you can use the cutter as a single instrument. Whether you want to cut the vitreous, you want to delaminate the membranes, you can see all these membranes being trimmed from the periphery to the center. And you can also alternate because of the dual linear foot switches when you want to control the cutting rate and the aspiration. Once everything is cut, these are the back flush needles where you can actively just flush out all the pre-retinal hemorrhages. Initially we were just leaving them alone and they say they used to get absorbed or not, but now we want to have a clean surgery, so maximum remove all the hemorrhages and a good adequate laser at the end of the surgery. And you can see once you remove these trocars, these are all very nice self-sealing wounds. These hemorrhages are sometimes because of the forceps handling the conjunctiva and not from the trocars. And you can see the eye is being quiet. So these are the post-operative results nowadays we are able to achieve even with phaco vitrectomy. Complications, yes, all surgeries combined complications are there. You might have the immediate post-operative complications like diabetic macular edema, cystoid macular edema, recurrent vitreous hemorrhages, and the late complications like the detachment or ERM formation. Post-operative treatment is we follow the same treatment regime that we use the steroids for 6 weeks in the tapering dose and topical antibiotics just for 2 weeks and cycloplegic in the first 1 week, one to relieve the pain, and we want a good dilatation so that we have an immediate post-operative view of the retina. So the main benefits, I would say, it's a single surgical procedure. It's faster visual rehabilitation and greater patient satisfaction. It avoids multiple anesthesia and multiple times to the OT for some complicated patients, because you know most of these patients are on renal problems and on dialysis and ischemic heart disease. Cost-wise, yes, also affordable when you compare it as two separate surgeries to one surgery. We need a clear intraoperative view of the posterior segment to actually know how you can see the problems in the B scan and tell it is a TRD and this thing, but only when you go in you will actually know about the macular involvement and where it is attached. And also very, very useful for post-op follow-up of the retinal pathologies. The main drawbacks you could say is surgically it is definitely more demanding and more time consuming. The surgeon should be well versed with both the machines, both the techniques. Or some of the main institutions, they have the anterior segment surgeon do the anterior segment part, and then they shift it to the posterior segment surgeons. They already published reports which say that these combined procedures are more and more frequently being done and are definitely useful. So in conclusion, combined procedures are an opportunity for the patient to undergo one surgery instead of two, with accelerated normalization of the ocular anatomy and rehabilitation of the visual function. All this is possible because of the advancements in technology, combined anterior and posterior segment surgical platforms, and the skills of the surgeons also. Thank you.